The first country we will hear about is Switzerland, and it's Stéphane Spahni who will take the stage. Stéphane is involved in IHE already for many, many years in IHE pharmacy, contributing really hugely, I can say, to IHE profiles on medication. But also in IHE-Europe, you have quite an important role. So please, the floor is yours.
Thank you, Esther. Good morning, everybody. So I will say 2 words about the situation in Switzerland. First, the electronic patient record, the basis, the foundation for doing other projects. We have a national law since 2017 with an implementation delay until mid-20 for implementing decentralized infrastructure, XDS communities. So we have now 8 XDS communities over Switzerland, where with the core services, it's managing the patient record, it's patient-centric, it's managed by the patient, controlled by the patient. There are web portals for the patients, for the healthcare professionals, and apart from the storage, the management of documents, there is one first structured document that is being introduced. It's the vaccination document that is being made available this autumn. So situation we have is basically this one. We have different communities, so different organizations managing the services, managing the help desk, the enrollment of patients, the marketing towards the patients, the healthcare professionals. And we have, for that, we have 3 different implementations. So 3 different times all the effort of implementing all the services of a community. It's strongly IHE-based. There is, I think, approximately 50 IHE profiles that are involved in such an infrastructure. And all communities, all platforms have to speak with the others. What the patient sees is the whole set of documents from all communities if he has been taken in charge in different regions. All communities are certified and live. We have a certification process, technical certification. We have projectathon since 2017. There is a yearly projectathon. In 19, during the connectathon here in Rennes, it was also run here. We have administrative certification too for the processes, the way the different things are implemented. There are still cross-community restrictions. It's very complex, like when a healthcare professional from another community is accessing your patient record, you need to be able to see in your record that the healthcare professional somewhere else had access to your patient record. So there are a certain number of flows of information flow between the different communities, and it's even with the interoperability standards, it's not easy to implement properly everything. EPR affiliation is mandatory for primary care, birth centers, elderly houses, and for newly installed private practices since beginning of this year. Note that affiliation is not synonym to accessing and publishing documents in the patient records. It's only the affiliation that is mandatory. So if you have a contract with the one community, if you have an account on the healthcare professional portal, you are conformant with the law. For patients, it's still an opt-in strategy, which means that we have now about 25,000 affiliated patients, opened record. For a country where we just reached the 9 million inhabitants a few weeks ago. And among that, there is one community, the one in the French-speaking part. No, it's not appearing. The one on the left, the blue, dark blue one, which has about 65% of the opened record for a population of 25% of the country. And that's mainly due to the fact that Geneva started the electronic patient record, was live in 2010 with another platform. We had 55,000 patient records opened when we stopped the old platform and moved end of 2021 to the new one. It's also linked to the way marketing is performed, the support we are offering to the patients. So regarding the usage of the platform, motivation for healthcare professional is rather low. So they have to affiliate, but they're not really using. The system is complex. The way to connect with the double factor authentication, all the process to get your EID, you need to have a certified EID. That means that you have to go to one of the 2 or 3 providers, do a video for being strongly authenticated. All the process is very complex. And there is clearly a lack of content. The University Hospital of Geneva is the key providers of documents. We have automatic publication, and probably more than 90% of the documents are coming from the University Hospital of Geneva for the whole country. And there is a strong lack of primary systems for healthcare professionals integrated with the EPR platform. So we need clearly to provide attractive services, things that healthcare professionals will say, well, that's really something I need. That's really something that will make the difference when the patient has it, when it's implemented in patient record. And one of these services is the medication, having a global view of the medication. Images access, Thierry mentioned before also the images access. We currently have the reports. We do not have access to the images. Strategy has been published. The way to implement it has been published by the federal government a few months ago, but it's being implemented in the technical platforms. It's not yet available. We would like also to work on the structured lab results. But I will focus now for the second part on the medication project. We started the project linked to the new law, the federal law, about 5 years ago. We had a previous implementation in Geneva on the regional platform from 2013, something like that. We have a clinical focus. The key thing we want to realize is to have a global view of the medication of the patient. That's it's not a logistical first, it's really the medical aspect. What is the patient taking? And for the healthcare professional and for the patient himself. Supporting, of course, prescription and dispense. It's very important to document also the dispense, to have the view of what really the patient is taking. You may have a substitution, you may have some changes during the prescription and the dispense, so it's important to know what is really taken by the patient. Contributors are healthcare professionals and patients. The patient is allowed to contribute to his medication record. He may take some medication he decided himself. He may add comments. He may change different things in his medication record. One drawback of being clinical oriented first instead of logistical is that we do not have any push, any support for making people use the system from insurance companies, from pharmacies, because it's first the medical aspects that is important. awareness of the importance of managing such a medication plan is still rather low. There is another parallel project in Switzerland based on the medication card. Medication card is basically what the patient is taking now. And if you want to have a history, you need to take all medication cards and see what is the difference between with the previous one. If you want to change, if you want to add a medication, you have to be sure that you have the latest medication card to do the change. Otherwise, you create a parallel track. But it's simpler because you just have the medication card. So there is some interest from healthcare professionals on the medication card. It's complex. If you really want to manage the global medication view, it means that if you want to add a medication, you first have to look at what the patient is taking now. And then you will add or change something. So you will have to implement a reconciliation process also in the primary systems. And the reconciliation has to be done at the level of the healthcare professional. It cannot be done automatically behind. It's really there that you have to implement that. It also means that we have common referentials and terminologies. So we have referentials for medication, many coded informations like intake path, like the galenic form, are based on local terminologies. So there is big work to be done to use international terminologies. And there's also a certain number of business rules to formalize. What is an active medication? Or if you have a prescription, how long is it valid? How long is it dispensable? There are different rules, and there is the duration written on the prescription, but the patient may start his medication, his intake a few days, a few weeks after. So how do you say, well, this medication is active? Moreover, we have different rules in the different cantons, saying, well, a paper prescription is valid for 1 year at most, or for 6 months, or for 3 months, and it depends on the different regions of the country. Exchange format is a key thing for implementing, for having the interoperability between the different systems. So we initially started a few years ago with the IHE pharmacy profiles, the CDA documents, the plan, the prescription, the dispense, etc. And last year, we had to realize that all new systems want to go FHIR. FHIR is the buzzword. Yeah, FHIR will solve everything. So we want to do FHIR, we do not want to do CDA at all. So initially we planned to support both and to have a conversion from one to the other. We decided to abandon CDA completely for the project, moving towards FHIR with a mix. The EPR platform is document-based. So we're still keeping the document aspects because it's compatible with the EPR platform, but using FHIR resources embedded into documents. So we have a document for the prescription, we have a document for the dispense, but FHIR resources based on HS7 resources. And we had to agree also on a subset of common terminologies. If you take administration routes, if you take the standard, you have something like 200, 250 administration routes. Who will work with that? Which GP will work with a menu of 250 values? No way. So you have to work on that. You have to constrain also the FHIR resources. Basically, everything is optional, and everything can be extended. In terms of implementing a primary system, if you have a lack of resources, moreover on this side, you have to limit the optionality to make it more implementable. And motivation of primary systems providers. First problem, very few have a deep integration of their system with the EPR platform, which is for us a prerequisite. They first have to solve the connection to the EPR platform with the strong authentication, with the access to the XDS-based repository, identification of patients, all that, and then they can add the top layer of the eMedication process, implementing then the business logic related to eMedication. And as there is a little demand from the healthcare professional, there is little motivation from the healthcare providers, the software providers to implement it. And as the software providers didn't implement it, there is lack of demand on the healthcare professional side. So that's a problem we are trying to address to solve that. Concretely, we are going through a proof of concept approach. We made an architectural design of the service, considering a national implementation at term. So considering the different communities, all the different things. We are developing a central service for managing, storing the medication of the patients, aggregating the different information, creating medication lists, creating the medication card, for example. All what can be centralized is centralized. However, the reconciliation process is not centralized. It's to be implemented at each healthcare professional system. And we are doing a proof of concept for the CARA EPR community. We're working strongly inside CARA with the different stakeholders of the community. We have 2 university hospitals that are being connected to the central service, the aggregator. We're working with not a pharmacy, a distributor of medication who is in charge of the national referential, trying to motivate primary systems and working directly with patients and healthcare professionals. Next steps, we'll have in the beginning of November 2 days, what we call focus days on eMedication, with the goal to motivate people from the different reasons, patients, healthcare providers, software providers, pharmacies, to have a common understanding of the different things, the key aspects, the challenges, identifying the blockers, potential solutions, and addressing also the key fears. There are fears from the healthcare professionals. Like, well, if I see what the others prescribed, what is my responsibility? If I see that a medication that is potentially bad for the patient, that will have potentially bad effects, side effects, am I responsible of this prescription or not? Shall I change it myself? What happens with that? All that kind of questions are here. There's a question also of transparency. The care itself is considered by a certain number of healthcare professionals are some intellectual property. And if I show what I am doing, I will lose my intellectual property because any other will see how I'm working, what I am doing, in which situations. So that's a certain number of things that have to be addressed if we want to have a success for the project. We expect to have a go live with a limited number of patients in spring next year, with patients from the 2 university hospitals, a patient portal enabling the patient to see what he has, to get the medication card, and to contribute, to add comments, to add possibly medication he's taking from a self-decision. And we're trying to have also a mobile app for patients, which introduces new challenges in terms of security mainly, management of the strong authentication on the mobile app, how it's recognized by the platform. Longer term, question is moving towards full FHIR, having a FHIR server on the central service, moving to IHE pharmacy FHIR-based profiles, which are work in progress, but probably next year we'll have something becoming usable. However, this will have a strong impact on the primary systems. They will have to change their implementation. So it's already difficult to have them implement the key things. We'll see. There are discussions in Switzerland around the distribution, the 8 communities, the 3 different platforms. It's the way to maximize the cost, clearly. So some are thinking at limiting this distribution, limiting these multiple implementations. And we should have a national eMedication law for implementing the real e-prescription. That's not for the coming 2 years, for sure. Hopefully, we have a strong political support. The proof of concept is led by the CAR-IPR community. The eMedication is a key project for the Canton of Geneva, where we are working, where we are developing the central service. And we have support from eHealth Suisse and the Federal Ministry of Health, who funded the architectural work. They are organizing yearly projectathon, and there is now, since 21, a part devoted to eMedication. And they are supporting the development of the standardization of the FHIR resources for the eMedication. Any questions?
Thanks. In the beginning of your presentation, you mentioned that you have gone for opt-in system for the patients. Is the partial opt-in also possible, or is it only full opt-in? So can I as a patient opt in for some services, or is it all or nothing?
There is the opt-in for the EPR, and it's opt-in for the EPR services. However, you can ask a healthcare professional not to contribute, not to publish some documents. Then there is an opt-in for the medication service. And the access rights will be managed slightly different in the medication service. In the patient record, the patient can hide some documents. We implemented the same rule in the early system in Geneva for the medication, but that's first very hard to manage and then counterproductive. So for the medication service, it's opt-in, but either you show your whole medication plan to a healthcare professional or you show nothing, but they will know. Regarding the EPR, there are discussions at the federal level to move to an opt-out for a revision of the law for 27-28.
I think we have time for one more question, if there is any. Yes, Jan?
Thank you for the presentation. I would like to ask, what was the learning curve when you were developing the EPR, the projectathons that you organize? Was the first one a success, or how did the vendors react? The learning curve, basically.
I would say slow, and particularly slow regarding vendors of primary systems. Probably only 2 or 3 are coming to the projectathons. I fear that as long as we do not have some kind of certification process for the primary systems, it will be difficult. And that was also shown by the presentation of Thierry, that once you introduce the certification, some kind of, well, it was even not mandatory, but you had a certification, so you had a plus, and that was a strong push for the developers to participate to the projectathons. The technical knowledge is very, very low in terms of interoperability.
Okay, thank you again. This is for you. Oh, okay, one more. The last question then.
Thanks. With respect to the idea of full moving to FHIR-based setup for the eMedication, IHE-XDS, of course, is a kind of distributed architecture with affinity domains concept, which is not yet, at least, available with FHIR. How would you see that?
We have a big advantage for the eMedication. The EPR is what we can call healthcare professional centric, in a sense that the healthcare professional publishes in the community he's affiliated to. And The patient record is the sum of the documents from every potential community. eMedication service, considering performance, complexity, access right management questions, we decided to have a patient-centric system, meaning that all eMedication information of one patient is in one eMedication service. So we can have one the file server will contain all information of one patient. We avoid the distributed file server for one patient, for which I think there is no implementation yet. One potential problem we may have that is already identified is related to security. If you need to have data encryption in the file server, it seems to have a huge impact on the performances for the search. So there are experiments to perform, optimization, what is encrypted, what is not encrypted, and possibly validation with the certification process that we are still compliant while preserving the performances. Because a physician doesn't wait 20, 30 seconds for getting the information. They abandon.
So thank you again for sharing the successes, but also the challenges that you face in Switzerland.